Go ahead.
Good afternoon, everyone. Myself, Dr. Kanchan Durugkar. I am consultant at Oasis Fertility, Wakat, Pune. Today, we are going to talk about IVF failure and what to do with what to do if we have a negative result after IVF cycle. So, today we are going to talk about what happens even that our IVF doesn't work or we don't get a positive result. What are the reasons that our IVF cycle has failed, and what to do? What are the investigations that we can go through, or what are the tests that we can go through and uh, find out the reason why our IVF cycle was failed, and then go towards the positive result. So, dear friends, let us have a small discussion about the IVF failure and what we can do for the IVF failure. So, as it is said that the failure is not a disappointment, but it is just an appointment of success. So, let us discuss about IVF failures and how we can achieve success and how we can achieve pregnancy even if our IVF cycle has failed. So, what are the success rate of IVF? First and foremost, we should understand. I know that it is very painful for any couple who are undergoing through IVF, that the IVF cycle, because we have very much hope from the IVF treatment that it is going to give, it is an ultimate treatment and it is going to give us pregnancy. But dear friends, IVF is not 100%. It is not the success rate of IVF is not 100%. Though we do it for any normal situation with young patient with normal good quality embryos, but still the success rate of IVF is not 100%, that we should accept before going for or when we are going through IVF treatment. So, what is the success rate of IVF? So, with the recent advances that we have, that is a T5 embryo transfer, that is called blastocyst culture, with the other advances like laser assisted hatching, then other advances like frozen embryo transfer. With these advances also, the success rate of IVF is around 60 to 70%. So why this 40 to 30% of the patients have negative results? So what can be the reasons? So, and in the this is the success rate, 60 to 70% success rate is for the day 5 embryo transfer, when we transfer the embryos that have developed till day 5. And if the embryos or the maturity of the embryo is day 3, then the success rate is even lower, that is 50% around. So why this success rate is low, that also we will discuss when we will discuss about day 3 and day 5. Now, coming to the causes, so why our IVF has failed. So actually, before going for IVF only, we do some primary investigations in which we see for the basic hormone test, then your egg quality, egg numbers, that is we call as a AFC count, AMH count, and also sperm analysis also we do. But sometimes these tests are not final tests. We may need to have undergo some other test also to see why the IVF cycle has failed. So in this, we should see for first the uterine factors. First and foremost, endometrium. We say it as a seed and soil. So soil is endometrium. So soil, endometrium, what was the thickness of endometrium? Was there any problem in the endometrium thickness, or was there any problem with the, you know, any adhesions were there, any septum was there in the uterine cavity? So these problems can be addressed by doing a simple test that is called as a 3D sonography. Generally, this 3D sonography is done after your, ovulation period, that is called as a luteal phase, that is around day 20 of the your cycle. So in this 3D sonography, it is not an invasive test, just a 3D sonography, a well done 3D sonography can give us a better, idea whether we should go for hysteroscopy, that is an invasive test, or it is, if the 3D scan is okay, then no need to go for, invasive treatment like hysteroscopy. So uterine factor can be very well, addressed by doing a 3D or 4D scans. So in this after this, if there is any problem, like if there is any adhesions, if there is any polyp or that has been missed in the previous, generally the if there is a polyp, that is generally addressed before first transfer only, because embryo transfer is a last step of IVF. So before going for embryo transfer, we generally address all the problems. If at all there is polyp or septum is there, then we generally remove that, and then we go for embryo transfer. But if at all it has been missed, or any septum is missed, any adhesion is missed, or the patient is having thin endometrium, then in these patients hysteroscopy is advised, and whatever the problem is there, that can be solved hysteroscopically. So it is not just a diagnostic hysteroscopy, but we do the diagnosis, see and treat. That is, we see the problem and we treat the problem. So this is about the hysteroscopy. Then other thing that needs to be addressed is sometimes the endings, sometimes the uh, now, before going for adnexa, we should talk about the embryo, that is a seed. That is the first point actually. So, embryo is a very important factor. Most of the time, the IVF is failed because the embryo quality is not good. So, why this embryo quality is not good? The embryo quality may be compromised because the egg quality was not good, and or the sperm quality was not that good. So, or both the quality was not that good. So if there is a compromised quality of these gametes, then the forming of embryo will not be of that potential. So most of the time, the reason is that the embryo that has been formed is not of that potential that can implant and give us a pregnancy or a live birth. So that is the most common reason that the IVF fails. Now, other reason can be, as a endometrium I talked about, and adnexa. Now, what is this adnexa? Adnexa is the structure that is between, outside the uterus. Now, the adnexa means if there is any tubo-ovarian mass or any hydrosalpinx, or that means if there is water is filled in the fallopian tube. So if there is any pathology in the outside the uterus, so that is called adnexal pathology. If this adnexal pathology is there, again it is going to hamper our implantation. Again, it is not going to allow the embryo to get implanted. So this adnexal pathology also needs to be addressed. So how it can be addressed? A good scan can first see, we can see for the adnexal pathology. But if at all we cannot see anything on USG, and there are repeated failure, other causes we cannot see, then the laparoscopy, and laparoscopy it is to see for any tubal or adnexal factor. And if at all any tubal factor is there, then the tubal clipping can also be done, that is, or tubal clipping, or tubal salpingectomy. These are also the methods for if the tubes are damaged, and these damaged tubes are secreting some fluid which are not allowing the embryo to implant. Then in this case, decision of lap clipping can also be taken, and this lap clipping can also improve our success of IVF. So this is about adnexal pathology. Now coming to egg quality. Sometimes egg quality is compromised. Sometimes we get number of eggs are more than 20. We get in the pickup, we see that number of eggs is very good, but the quality of the eggs are compromised. So their fertilization potential is compromised, and the embryo that are formed with this So some technical glitch was there. So there can be a problem with the embryo egg quality also, and this problem can be addressed by changing the protocol. We can or changing some tablets. We can improve the egg quality, and then we can again go for embryo formation, and that time we can get the results. Now genetic problems can be there. So for this, a simple test of karyotyping. Karyotyping is a very basic genetic test basically. So karyotyping can be done. Complete exome sequencing and other higher end tests for genetic evaluations are there, but generally first and foremost, most of the time this basic genetic test, that is karyotyping, is not done for the patient. So this genetic test is done, and if at all any problem is there in the genetic testing, then we can go for the higher advanced fertility treatment that is called as a PGTA and PGT-SR. So if the repeated implantation failure is there, then there can be a problem in the embryo, that the embryo is aneuploid. It is not a euploid embryo. It is normal genetically, not a normal embryo. So in these patients, PGT-A can be done, or if there is a specific structural rearrangement. So that is called as a structural reason. That is problem with some specific structural problem is there in the genetics, then the PGT-SR can be done. And other is the monogenic problem. Monogenic problems are generally for prior known. So PGT-M is also there, but this PGT-SR and PGT-A are specific for the structural rearrangement and aneuploidies. So PGT-A can definitely improve the success rate in the patients with repeated implantation failure, in spite of transferring good quality embryos. So basically the quality of embryo is what it is, the grading that is given by seeing the embryos under microscope. So they are not genetically tested. What we have a perception that since we have undergone IVF, they are genetically normal embryos, but it is not like that. It is natural fertilization that occurs. We have achieved that fertilization in the lab, but that fertilization is achieved in the lab and we have formed a D5 embryo. That doesn't mean that it is a genetically normal embryo. To see whether it is a genetically normal embryo, we have PGTA testing, that is called as a pre-implantation genetic testing for aneuploidy, or for structural rearrangement it is called as a PGT-SR. So these two recent advances can help us in having in the patients with repeated implantation failure to achieve pregnancy. Now, coming to other causes. Now, what can be the other causes? I have talked about the laparoscopy for the patient with adnexal pathologies also. Now, if previous history of the patient is also important. If the previous history is only day 5, day 3 transfer has occurred, or fresh ET has occurred, then definitely the other advances that are there, that day 5, going for day 5 culture, then going for frozen embryo transfer, going for laser assisted hatching, this this can also improve the results for the patients. And if at all the embryo quality was very much compromised, and there is an age factor also, or the poor ovarian reserve is there, then though it is a last resort, but going for donor gametes, like donor sperm, if the sperm quality was very much compromised, or going for donor eggs if the egg quality was very much compromised, this can definitely improve the success rate. Excellent success rate are there, but only thing is we have to accept that treatment, that we are going for this donor gametes. So this is about the if the quality of the gametes is compromised, then going for the oocyte adoption or sperm adoption. So this is about the changing the gametes. Then if at all any uterine pathology is there, then I already talked about we should go for hysteroscopy. In this see and treat with that we should do. Along with that, PGTA and PGTM also I talked about. So immunological factors can also be there. Like we have sorted that euploid embryo we have got, and we have good endometrium also. So no problem with seed and soil. So these two problems we have sorted, but still there can be some immunological factors, like the mother is not accepting that embryo. Some immunological antibodies are there in the mother's body that are not allowing the embryo to implant. So what can be done in these patients? So some researches are coming up which are showing a good result with the some IV preparations like intralipid and intravenous immunoglobulins. This has definitely shown some ray of hope in the patients with repeated implantation failure, and also in the patient with repeated pregnancy loss. So in these patients where immunological factors was a concern, in these patients definitely it has somewhat given a ray of hope to improve the success rate, and of course the live birth rate, the live birth rate in them, I mean that giving them a live baby. So this has the intralipid and IVIG has come up. Lead therapy has also come up for the patients with immunological factors, which was actually it is still in the experimental process, but lead therapy has also come up, where we take the blood from the paternal side, the father side, and we inject it in the mother, so that she gets the positive response to paternal blood, and then the process of embryo rejection will not be there. So these are the different newer therapies that are coming up. Even there are other therapies like PRP injection, intrauterine PRP, instillation, and other therapies also are coming up, which can, in some or the other way, improve the success rate. Low molecular weight heparin has also has shown the promise in the patients where we are not able to find any cause of repeated implantation failure or repeated pregnancy loss. So in these patients, low molecular weight heparin has also shown the some promise for this patient. So these are the different modalities that we can try. So if the IVF your cycle has failed, that doesn't mean that your hopes of having a baby has come to an end. It is not like that, but only thing is we need to properly evaluate. We need to sit and talk. You need to sit and talk with your consultant, get a positive energy, and whenever you are prepared that yes, we are having trust in this treatment and we are going for this treatment, then we can go. And of course there is a last sort of surrogacy whenever when it is said that the endometrium is not at all getting ready for implantation repeatedly, it is showing thin endometrium or repeated implantation failure are there, then in these patients surrogacy can be a last option where we can get a good result and the live healthy baby. The surrogacy can be a last option for these patients. So this is about the what are the treatment that are available. Only thing is what 100 treatments are available, but what is the cause of failure in my patient or the couple which is coming, then what are the treatment that are available for me to offer, and accordingly what can take us towards success and a healthy pregnancy is the thing that needs to be sit and talk with your consultant. So this is all about the IVF failure and how it can be dealt. Of course it is not the end of the journey, it is just a hurdle that can be passed and we can move ahead towards success. So I think that is all from my side. I think I have addressed whatever treatments, recent treatment that are available with us at Oasis Fertility. Also at Oasis Fertility, Vakad and Kharadi, Pune, we have all these recent advances of fertility treatment that are available at national level. So whatever queries you have, you can come up. Our helpline number are there. Our consultation is there at Vakad and Kharadi Center. So please feel free to contact us. And I wish you a healthy and happy family for the even if the IVF has failed, it can be dealt with and you can go towards success. Thank you very much. If at all there is no question, we can close this session. What should I do after a failed IVF? So, as I told in this session, that failed IVF is not the end of your IVF journey. You can definitely have your consultation with your doctor, and whatever the issues that were not solved or were not addressed in the previous, IVF cycle, that can be, you know, uh, taken into account or can be addressed, and then if that they can be solved, and we can go towards the further treatment. What is the success rate of IVF after a failure? So again, the second IVF failure doesn't mean that first IVF failure has failed. That means the second IVF failure will have a low success rate. It is not like that. Even with uh, first fail, the second will have again 50 to 60% success rate will be there. What is the next step? So next step is first to get your endometrium evaluated, uterine cavity evaluated, either in the form of 3D scan or in the form of hysteroscopy. And if at all there is no problem in that, then see for the embryo quality. As I said, that embryo, that is the seed and the soil, these are the two main important things. And if the embryo quality is okay, then we can go for the whatever sets of embryo, extra embryo that are available, we can go for those embryo transfer. And if at all the embryos are compromised, embryo quality is compromised, then we can go for other next stimulation, that is again formation of embryos and then transfer of those embryos we can go for. Can hysteroscopy help it? Definitely, hysteroscopy it can help infertility, but it is not that if the one IVF has failed, then hysteroscopy is for every patient. It is not like that. Or if the patient is undergoing IVF, then hysteroscopy is for every patient. It is not like that. Only the patient with the good 3D scan, we can, as I told in this session also, that with good 3D and 4D scan, we can address maximum of the uterine pathologies. If at all there is still a doubt, there is any polyp, any septum, any adhesions or thin endometrium, for that hystro-PRP or polyp removal or septum resection, whatever the problem is there, that can be solved with hysteroscopy, and definitely we can improve the implantation rate and live birth rate or pregnancy rate for that matter. I think that's all from the question answer side also. So we'll close this session. Thank you very much. Thank you for your patient listening.